You're now live, Chair, and I will leave you.
Thank you, Gordon. I will make a start then. Anybody watching, apologies, there was a short technical hitch while we had to get the technology to work properly, but welcome anyone who's watching to this meeting. As you might notice, it's quite a quick meeting after our last meeting due to just the timing after Christmas and February being a short month. And we're still in a level 4 pandemic management. So there isn't an extensive agenda today. So it will be a relatively short meeting. Just take an opportunity to start just to thank all our frontline workers, the volunteers and everyone behind the scenes who's been helping to deal with all the patients with COVID and also have delivered an amazing vaccine program which is doing very well in Rotherham at the moment. Right, we'll move on with the agenda then. Have we got any apologies from anybody? I think everyone's here that I can see. We can welcome Ben when we do the introductions, as we have a new Director of Public Health. Sorry, Lindsay, you say there was an apology?
No, I've just noticed Dr. McEwen managed, he did say he may be late.
Yeah, he was, yeah. Okay. So we'll do some introductions as we have our new Director of Public Health, but we'll just go round and I'll leave Ben till last to introduce himself. So I'm Richard Cullen, I'm a GP and I'm Chair of Rotherham CCG. Janet?
I was trying to get myself off mute. Janet Weekly, I'm lay member and Chair of the Primary Care Committee.
Debbie?
Good afternoon, everybody. Debbie Twell, I'm lay member for Patient and Public Engagement.
Simon?
Hi, I'm Simon McEwen. I'm Vice Chair of the GP Members Committee.
Ruth?
Ruth Brown, Assistant Chief Officer.
Jeff?
Hi Ben, Jeff Every GP, Blythe Road, Maltby, Chair of the Members Committee and CD for Maltby Wickersley PCM.
Sue?
Good afternoon, I'm Sue Casson, I'm the Chief Nurse at the Clinical Commissioning Group.
Brian?
Brian DeCosta, Consultant in Diabetes and Endocrinology at Mid Yorkshire Hospitals and here as Secondary Care. And welcome, Ben.
Jason?
Hi, Jason Page, GP, Vice Chair.
Okay, David Clitheroe?
David Clitheroe, GP. I'm here as the independent GP member.
Chris?
Chris Edwards, Accountable Officer.
David Roach?
Hi, David Roach, Chair of the Health and Wellbeing Board and Cabinet Member for Public Health and Adult Social Care Council.
Wendy?
Hello there, I'm Wendy Ellett, Chief Finance Officer.
Ian?
Afternoon, Ian Atkinson, Executive Place Director from CCG.
John?
Hello, I'm John Barber, lay member of Good Governance.
Lindsay?
Hill, minute taker.
Okay, and then Ben, if you'd like to introduce yourself.
Yeah, hi everyone, and thanks for the introductions. I'm Ben Anderson, so as Richard says, new Director of Public Health for Rotherham and started in the council start of January, so nearly a month in.
Okay, thanks Ben. Welcome your input to all our decision making on the board. Okay, moving through the agenda then, we are quorate. Are there any declarations of interest for any specific items? Okay, are there any patient or public questions?
No, Chair, nothing been received.
Okay, moving on to the draft minutes of last month. For the accuracy and anything else, we don't have an action log because there was no outstanding items, so just raise anything as we go through. Page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and 11. Okay, Thank you then, Lizzie. We'll take that as an accurate record. And there is no action log. So Chris, Chief Officer's report.
Yeah, again, just a brief report this time because it's so soon since we last met. So just a couple of items in the spirit of transparency. So there's 2 services which were coming to their contractual end. So the teledermatology service, we've extended the contract because running a live procurement competitive process at the moment is not deemed fair on providers to be able to resource getting bids together in a level 4 emergency. So we've extended that until October 2021 to allow a fair competition. And the minor eye conditions service, which has been reviewed, and at the end of the contract, we've decided not to re-procure the service. So just really for information and transparency there. But if anyone's got any questions, happy to take them.
Jeff has his hand up.
It was just a note from when we discussed the members committee, Chris, as far as minor eye conditions, was set out to sort of say, did it save the hospital in terms of referrals and money, which made it affordable, which I think from sort of saying it hasn't sort of proven that, but actually from a service point of view in terms of primary care and for patients and GP forward view in terms of GP time, it's actually in primary care sort of deemed as actually quite a useful service. The difficulty sort of comes that if the hospital hasn't got any funding for it and the CCG hasn't got any funding, and PCNs in a sense have funding, but most of it's in additional roles, and it's difficult to see how that sort of ties in sort of expanding this. So yes, it's sort of set out as to start with, does it save hospital money, which allows it to be funded, which it hasn't, but actually is actually quite a useful service to patients in primary care, which I think we sort of did say with Ian, we were going to try and pick up outside of members committee. So I appreciate sort of in terms of governing bodies, sort of that's what the outcome is, but actually in the wider sort of health point of view, actually, I do feel there's sort of a potential sort of thing there to say, is that something we can try and sort of resource, but it may be difficult with what pots of money that sort of attaches to.
Thanks, Jeff.
Thanks, Jeff. Any other questions for Chris? Okay. Chris, then you were just going to update on the integrating care changes to the NHS.
Yeah, so it's just really a process update rather than anything else because we haven't had any further information through yet. So just to remind everybody, the integrating care document and the future of the NHS document was published in December, and there was an engagement period where we were asked to provide feedback for January the 9th deadline. We responded as part of an ICS and as part of the Rotherham Health and Wellbeing Board with the 2 responses the CCG were involved with. The actual document, obviously the colleagues in NHS England Department of Health will digest the feedback and then come up with a final document. I don't know when that will be published. I'm assuming it will be sometime during February is my assumption, but I don't have any particular information about when that will be published. And the suggestion is as soon as we receive that, then the governing body would receive that and then we'd consider next steps together and how best Rotherham as a place would respond that to make sure we get absolutely the best for Rotherham patients around whatever new direction our system's taking. So Chair, with your permission, I'd like to just be flexible with future agendas and when it arrives to put it on the first available agenda so we can discuss it.
Okay, that's great. Yeah, I think that'll be good. Any questions or any comments about that for Chris? All right. Okay. Moving on then. It's you again, Chris. You packed the agenda with things for you to talk about this month, Chris.
Hold on a second. I can't move as quickly as that, I'm afraid. I'm flicking between documents. So in terms of the next document, what we've got is the Integrated Care Chief Officer's Report. This is a monthly document that's written by Sir Andrew Cash, and obviously it's a summary of where we are in terms of our South Yorkshire and Basset Law ICS. My intention is probably not to go through the document, just go through, but I'd just like to assume people have had a chance to look at it and take any questions, Chair, if that's okay.
Okay. Any questions for Chris on that paper, on that update?
It should be business that's come through our governing body and there shouldn't be any surprises in there. So, but if anyone has any questions, I'll be more than happy to take them.
Okay, I don't think there's any questions about that then, Chris. Which means we'll move on. Wendy, finance and contracting.
Thanks, Chair. Hello, everyone. So this month we've got the report at the end of December, month 9. Sorry if you just bear with me, I've just lost my report. Apologies. But there were just 2 main items that I wanted to draw everybody's attention to. I've gone and lost it, so I'm going off piste. And they were that in sections 2 and 3, that cash is still being well managed and we're achieving the 100% payment target in line with the national guidance. And then the next thing is that on the OCS in section 5, you'll notice that this month we're reporting a surplus. I think last month we reported a break-even position, but flagged the potential for that to turn more favourable if the growth in prescribing remains suppressed at the more recent rates. And with that having happened, we've seen a further month's prescribing data. So we have now revised that forecast. And that's what you're seeing there. So we've got 1 million year to date and 1.3 for the forecast outturn. We flagged that with the ICS, and we have made it clear that that surplus is on condition of that we still receive the hospital discharge programme funding that we are expecting. So that's all flagged in our returns. And that was it from me, really. They were just my two main things to highlight to you all. Happy to take any questions.
Okay, thank you, Wendy. Jeff has a question.
Sorry. Yes, thanks, Wendy. It's like your analogy with landing the jumbo jet last year, isn't it? That it seems to change so rapidly, and almost like with Ian trying to predict the weather for Sunday as to whether we go ahead with the vaccines of different sort of plans. So, I mean, it's positive we're sort of at that point, isn't it? But so sort of unpredictable from one month to the next in terms of that. That's positive. The only thing I think I'd said previously, just for future issues, we were sort of sat a few months ago that when we were sort of overspend about how do we sort of tackle that. The prescribing again is like so difficult sort of to judge. But I've still said this. I still feel there's sort of elements that the prescribing changes maybe because of COVID and sort of other bits and pieces, isn't it? But I still feel in the future, if we're looking at trying to sort of help in terms of budget, this scope for primary care to sort of look at its prescribing costs, as long as there's the resource for that and the sort of motivation as far as that. So it doesn't matter sort of this time, but when we've sort of for the last however many years been when we're looking at overspending, how do we sort of tackle that? It just shows how much sort of prescribing sort of plays a part with that, doesn't it?
It does, yeah, and thanks for that, Jeff. I mean, we still have the prescribing incentive scheme running, so would agree, and the meds management team haven't completely given up on all of the quips that they set off to achieve, because I think it's where it makes sense to do a change, and it's achievable for everybody to come along with that, isn't it? It's that keeping us working together thing. So yeah, I appreciate your comments on that. Thank you.
Thanks.
Okay, any other questions there for Wendy? Sorry, did I see your hand go, Debbie, or was that just I just saw a flash of a hand go up in the screen on your thing, but it was obviously something else.
Sorry, Chair, I was removing something from my eye. Sorry.
All right, that's okay. I'm eagle-eyed. I can spot.
I'm glad. Being a doctor, you need to be eagle-eyed. I'm pleased to hear that, Richard.
I suppose, Richard, with you sort of saying that we've had this before, if there is a surplus and it's now sort of February, do we sort of have thoughts of sort of what that might get pushed into without sitting back in the pot?
So this one, Jeff, this bottom line is what we flagged with the ICS, just to sort of indicate that this would be a contribution, if you like, back to the system. Because it's an absolute surplus that's mainly come around through at months 1 to 6 when we were doing, we had the retrospective COVID claims. and because prescribing data is 2 months behind, therefore we made a claim that was based on some assumptions about months 5 and 6. And when we have month 5 and 6 data, we didn't incur that amount to spend. So actually we've been given funding, which then it turned out we didn't need, and it's come from the COVID pot. So that's why we have declared this surplus. And it feels right that we do that and offer that back to the system. So we wouldn't be looking to consume this within Rotherham at this point in time at all.
Yeah, that's fine. I mean, we have had it before, haven't we, where it's a bit breakneck, sort of where can you spend it? If we know that that's going back, it's not then a question of where is it, sort of, because sometimes it feels when you sort of spending that at the last minute, it's like wasted money, isn't it? If that, in a sense, is what not as such we borrow, but we've took out the system to put back into it, then that's fine. It's not that we need to be mindful of what we do with it. You've already earmarked that, yeah.
Yeah.
Okay. Any other questions? Thank you then, Wendy. We'll move on to Ian with delivery dashboard.
Yeah, thank you, Chair. So just under enclosure 10B, if we can, colleagues. So the delivery dashboard, again, for Ben and others maybe watching me report this by exception in this meeting. And again, it's a common approach in terms of how the position's been for the last 3 to 4 months now with regards to operating the system during the height of kind of wave 3 for the Rotherham Place. I suppose just reflecting before to support the commentary here, Rotherham Hospital continues to be under significant pressure with regards to COVID activity in the hospital, and then that flows through into the narrative in this report, Chair, and also with regards to the reflecting performance, having experienced this pressure pretty consistently since October and all the way through November, December and into January. So again, by exception, you can see the A&E performance. Again, we're looking here just as a bit of a high level on attendances, because TRFT continues to be part of the national pilot on A&E reporting, which is not in the public domain. So you can see the blue line there on attendance of pretty low still comparatively to previous years. And now actually we're starting to compare with this time last year, was still low in that space as well. As we go through the report, we look at our IAPT position for mental health, improving access to psychological therapy. On the whole, the services are standing up well in this space. We have seen some additional activity flowing through, but we are complementing our local service via the IESO digital offer. And again, that's supporting people with regards to their mental health needs. Our cancer position continues to remain very challenged in the Rotherham Place. You can see the position there up to November, and a deteriorating position there in November, and some real challenges we've gone through into January, and that will flow through into our next report next month. And again, trying to make sure that we hit the 2-week wait targets on 31 days as well as 62 days, really challenging for the Rotherham Place at this point in time. And I think I'll just comment finally, Chair, before we open up just on the 18-week pathway. We do need, you can see there within the report at 72%, it's not where we want to be. It is pretty much in the pack regionally and nationally on 18-week recovery, linking that to increasing numbers of 52-week waiters. We will be having dialogue probably in the next month or so with TRFT and wider colleagues in South Yorkshire around our strategy for recovering elective care, which won't be a short exercise in recovery, but we need to reset our plans as we did last September in the public domain with regards to try to get our elective profile back in line with our expectations on performance. So I'll pause there, Chair. As usual, just happy to take any comments or questions, but it is a challenge position for the Rotherham Place, like many other areas across the country.
Okay, Jason, then Jeff.
Thanks, Richard. Just to give a little bit of extra information on top of what Ian's done. On the 2-week waits for cancer, unfortunately, we didn't meet that in the last month. And that was just down to one person being off sick. And it just shows some of the difficulty in our system that we're so dependent on 1 or 2 people in various places. The good news, however, is on the 62-day waits, although on the dashboard it looks as though we're deteriorating, and on the figures we have slightly, but the good news is that a lot of the backlog that we have for cancer diagnostics is on endoscopy, and the Trust have put an excellent plan in place and have started, and at last Cancer Delivery Board, we're 2 weeks ahead of that recovery plan in terms of getting endoscopy back on track. And so that is causing a significant amount of the delays for cancer wait. So I'll be hopeful that we should start seeing some improvement in that data fairly soon. As I say, they're ahead of track. Thanks.
Thanks, Jeff.
Yeah, thanks, Ian. Yeah, just to note in terms of ambulance service, I think that's been one of those things for sort of perpetually that was sort of scoring poorly, and then actually at the moment is scoring well in most areas. I'm sort of aware that a few weeks ago, I think they had extraordinary sort of demand, which wouldn't sort of help things. But do we know what sort of the demand on the ambulance service is at the moment as far as that? Is that because the demand's become a bit more manageable?
Yeah, thanks, Jeff. Just on the kind of intel, although it won't play out in this report at the moment, in terms like if we think back over the last 2 or 3 weeks, which is like first couple of weeks of January, which is traditionally the busiest time of year in the NHS, we have seen real challenge at the front end of the hospital, as we've seen for a number of months prior to Christmas. I think we usually average about 70 ambulances a day into the Rotherham place. It hasn't been significantly above that number, but it's linked to the handover position now. TFT have significantly improved on their handover position, and they're performing pretty well in that space. But I think it's more the odd day, Jeff, where we get the peaks, as opposed to sustained pressure on the Rotherham part of the system. I can't comment further with regards to the wider South Yorkshire view on ambulance, but it's not something that is raised routinely as in on a daily basis as part of a concern for us at the moment in terms of handovers. But it is a challenge.
Okay, Ben.
Yeah, thanks, Richard. Just thanks, Ian, for the report. And looking at the performance, obviously it's not where we want to be, but compared to a lot of the country, we're still doing a good job. But I guess my question's around where we are behind on waiting time targets. What's the harm review process, and are we looking for any disproportionate impact on different communities around additional waits or additional harm that's happening during that time as we deal with COVID?
Yeah, I think it's a really good question. I think we need to approach the dialogue on recovery, not just at a Rotherham level, but at a South Yorkshire level, Ben. I think we've got to be having the discussion, and we will be proactive in this discussion around some of the challenges that face probably the smaller DGHs across South Yorkshire, how we recover them at the same pace as some of the larger ones and some of the larger hospitals around. Because if we're not careful, we can see from the report there, we've got 650 people now waiting over 52 weeks in Rotherham. That is not out of kilter with the South Yorkshire view or a national view now. However, we need to have a consistent approach across South Yorkshire to getting into those numbers, and there is a risk there. And I think we do need to have a different approach around harm reduction with our waiting list, as opposed to take the longest ones all the time. So we'd welcome your support with that as well, Ben, I think, going forward.
Okay. Ryan?
Yeah, just thanks for that, Ian. Just to share a little bit of the secondary care perspective, because certainly within our own trust, the respiratory team is pretty much on their knees with coping with patients with COVID and managing RQ, as well as coping within their own specialty with high levels of sickness. So the knock-on effect, therefore, is that cancer MDTs and clinics, although they are trying their best to try and support that, there will be consequences out of thought. And I think one of the other things that we are seeing, particularly at the front end in the context of general medical take, is that there are significant number of patients coming into hospital with having had delayed their treatment for whatever reason. Perhaps they were too frightened to come into hospital, or whether they have actually had difficulty accessing care. And I think that is something that we are probably going to see a lot of patterns emerging in the context of the post-COVID. Within our own hospital, we are actually struggling to put in place our own recovery plans within my specialty, that is diabetes and endocrinology, because all our clinics have been cancelled and we are supporting the front end, covering other wards and looking after other patients. So I think the picture is going to be pretty similar at your local, Rotherham Trust as well. And I think these impacts will be seen as well in other specialties.
Okay, thanks, Ryan. It's going to be a long journey back to getting everything back to how it was before the crisis. We'll just have to work at speed but carefully to make sure no one is left behind. Any other questions for Ian? Ian, do you want to just go on and just a brief update about how we're doing with COVID and vaccination? Anything you want to update the board about?
Yeah, I can just mention vaccination position, Chair. So we have targets, we've had targets, should I say, for the end of January to vaccinate and offer vaccination to all our care homes, which the Rotherham Place achieved. A real huge effort by primary care in that space. We continue to work with our care homes and the care home sector to identify anybody that may have not come forward for the vaccine or may have not been well enough to take the vaccine, to ensure that we get as much compliance in that vaccine. And again, working with Ben in public health has been really supportive in trying to just work through how we can target some of the care homes where we might not have had the uptake that we might have wanted. The next key deadline for the country is this 15th of February target for the top 4 cohorts, age 17 above, clinically extremely vulnerable staff and the care homes. So we are confident of delivering against that target, Chair. I'll describe in the confidential session a little bit later further assurance with governing body as to why that confidence is in the system. But I can confirm that we've had a good supply of vaccine over the last 4 weeks since we last met. And our PCN colleagues have absolutely delivered in line with the plan that's been set, as have our hospital colleagues within our hospital hubs with regards to delivering in that setting. So yeah, a positive month. And again, a huge thank you to all our staff, all our volunteers and colleagues working on the scheme, which has delivered a really, really successful first full month in operation since you last met. Okay, thanks, Jack.
Okay. Thanks, Ian. Sue then, moving on, patient safety and quality.
Thank you, Chair. Just a few things I'll mention as you go through the report and then take questions if that's okay. So starting off there on page 1 with the overview of healthcare associated infections across the patch and the investigation processes that are underway, giving an overview of that, you'll see that the trajectories for both the CCG overarching trajectory and the Foundation Trust are quite challenging this year and challenged, and root cause analysis is being undertaken to determine any lapse in care, enabling measures to be taken to avoid similar issues going forward. This work is facing challenges due to the additional pressures from the response to COVID-19, as I'm sure everybody appreciates. You'll see also E. coli numbers, though well under trajectory for the Foundation Trust and for the CCG overarching figures, and just exceeding the trajectory for the year to date there. Just to mention as well, with regard to a general comment about quality monitoring, all quality monitoring is still being undertaken both together at a local level through contract quality meetings at place, certain areas around safeguarding at place, and also regionally with NHS England and improvement. And although that's becoming at times quite challenging, that work is still being undertaken, and I did want to mention that. The CCG infection prevention and control nurse continues to support into vaccination sites, the GP hub and into care homes, and with an overview on page 3 there. The Foundation Trust Mortality Task and Finish Group continues to review all mortality, particularly in relation to a number of diagnosis groups respiratory conditions, including pneumonia and COPD, where they are outliers, and this work's led by the Chief Executive and the Medical Director. NHS England and Improvement are closely involved and kept fully cited via on the work via site visits and the regional quality surveillance group. Page 5 starts with the safeguarding section, including an overview of safeguarding work and information shared across primary care. You'll see the updates on the Ask for Annie Domestic Abuse Code Word Scheme. And Annie, ANI, it stands for Assistance Needed Immediately. Also Professional Curiosity and the Safe Sleeping campaign, which is taking place across Barnsley and Rotherham, and CQC activity. Forward on to page 9, showing a very small number of very complex patients in the delayed transfer of care for both adult and older people's mental health services. These patients require very careful planning to ensure the most appropriate care is in place for them. And towards the end of page 10, looking at the Foundation Trust are continuing to address the actions put into place to achieve the recommendations from the CQC with regard to the last 2 reports published. And they continue to report to the CQC fortnightly, also with weekly support calls with the CQC. The safeguarding actions are also reported on and updated to the Rotherham Safeguarding Children Partnership, and assurance meetings taking place between the Foundation Trust, the CCG, RMBC and the Safeguarding Children Partnership. And the report ends on page 13 with a new update included for the first time regarding individual funding requests with a brief description of the process. And I'm happy to take any questions.
Thank you, Sue. Any questions for Sue on this paper? Okay. Thank you very much then, Sue. Shall we move on to engagement and experience report for you and Debbie?
Thank you. I hope I can stun you into silence again. So we've included feedback, quite a lot of feedback that we're receiving from vaccination sites across Rotherham, and it comes from a variety of sources, from patients, from relatives who've attended, and from volunteers. We've had filled over 500 volunteer sessions across the patch, and I think there are well over 200 people on the list that Helen and Dell manage of people who have put themselves forward to be volunteers on sites, with some people regularly attending sessions at a variety of sites. The vast majority of the feedback is very positive, and the teams are working hard to learn from all the feedback and review processes to make improvements. And I know we have been able to change things to make things better in a variety of sites in response to some of the very appropriate observations that have been fed back to us. I'd said about the number of volunteer sessions that have been filled across Rotherham, and they do continue to increase. There wasn't anything else I was going to mention other than to pass over to Debbie.
Yeah, that's fine. So just if you multiply up the number of, as Sue was talking about, 200 volunteers, 500 volunteer slots last week. Each volunteer slot lasts for about 4 hours. So last week we were able to cover 2,000 hours, which I think is incredible really for the volunteers that are working alongside all the clinicians and professionals at the vaccination centres. We obviously work quite closely with our partners, Voluntary Action Rotherham, and they've been doing quite a lot of work lately with regards to mental health, working with RDASH and trying to increase, to have a better network for patients and users' voice really. A part of their work, but not directly linked to that part, is that they've just, to be congratulated really, they've just received a lottery bid for working with children and young people for their mental health. And it was a sizable bid, it's in the public domain, so it was £100,000, which is to allow Voluntary Action Rotherham to support all those voluntary groups that work with children and young people, specifically to help improve mental health related to the COVID situation, which I think is phenomenal, and congratulations to them. Some of what I'm just going to say is actually Appendix 15, because this month we were so busy, Helen was so busy, and the team supporting the vaccination volunteers programme that we stood down our patient and engagement committee, and instead what we did was we got all our partners to sort of feed in, and Appendix 15 there is our alternative. It's kind of like an information sheet of what everybody's been involved with, and you'll see there's an awful lot of work going on across place to do with volunteers, to do with vaccination, winter communications, that the CCG are responsible for making sure we're getting to the right people and to those hard to reach demographic groups, and all the work that we're doing with regards to supporting everybody in the place with their mental health, regardless of age. So it's a busy time at the moment, and Helen and the officers that are responsible need to be congratulated for carrying all of that, I think.
Thank you, Debbie. And just like to say, I mean, the volunteers I've been working with have been working 6-7 hour shifts. It's not just 4 hours. It's and as my daughter's been volunteering, I have heard long and serious arguments about 6 or 7 hour shifts, but they're all doing it.
And very insightful, aren't they? With how to make it better.
They're making it, and we couldn't do the vaccination sites without the volunteers.
We absolutely couldn't.
David and then Jeff.
Just to say, I mean, I've said this earlier this morning, but as this is a slightly different group, just to say, as a recipient of a COVID vaccine, yes, I may not look it, but I am over 70. The volunteers have done a fantastic job. I mean, when I've seen pictures on the screen, TV elsewhere, long queues outside, and by the time I arrived at my centre, booked in and been injected, it was 4 minutes. I was amazed. The volunteers are doing a fantastic job, and I am also getting very positive comments from other residents and other councillors.
Thanks, David. Jeff?
Yeah, I think just to say that the support from the volunteers has been great, and staff, they're sort of almost the oil that makes things work as far as that, and in all sites as far as that, and also just to recognise Ian and his team for the support from the CCG, from PCNs in terms of what's been put in. I just don't want Sue to gloss over the bottom of page 3. I know she writes the report, but Sue and Stuart Abbott also is one of our managers in terms of their recognition that someone's put in there as far as the organisation, which again has been fantastic. Stuart's, I know that's happened in all the sites, but Stuart's put loads of work in. Sue is down there sort of almost all the time working, and Sue's husband Pat, who regularly mans the allowing the people in the car park in all weathers, and it's not just them, that's happening sort of all round. But yeah, just didn't want you to gloss over, Sue, the fact you'd made it into your own report there.
Thank you. There are a lot of names make it into that report, and unless I can get people's consent, I take them out. However, I consented for myself and Stuart.
but as I say, it is important. It is lots of people with that, but say there's you are all doing lots of good work. Thank you.
Okay, thank you. Any other questions for Sue or Debbie? Okay, well, moving on then. Minutes from other meetings. Janet, Primary Care Committee.
Yeah, thank you, Chair. This is the minutes from the meeting in December. I'm happy to take any questions. The only thing that I would sort of note and report is that we received a report on the GATE 5-year contract review, and the committee approved the extension of the GATE review for another 5 years with some revisions to the KPI requirements and the funding allocation. And I'm happy to take any questions or comments other than that on any other part of the minutes.
Okay, any questions or comments for Janet? Okay. Let's just move on then to Remuneration Committee. There is a decision in here for the governing body, and I think we did agree previously there would always be a covering paper to highlight the decision we needed to make. So I just apologise to anyone seeing the papers that this wasn't highlighted. Janet, do you want to just go through the paper?
Yeah, thank you, Chair. This was a meeting that we held on the 13th of January, and it was to discuss a paper that we'd received from HR about guidance issued from NHSE in December on for VCIs for very serious managers' pay increases, and also to decide whether to agree to mirror this award to other governing body members. The award is 1.0 1.03%, and the costs are approximately just over £10,000. And the approach was similar to what is the process that's going through agreement by other CCGs in the area. And also within Rotherham, in the past, it has always been custom and practice to extend the award for VCMs to other government body members. Because of the nature of the people involved in the committee, at some point, all of us had a conflict of interest. And so what the minutes show is how we manage the conflict of interest in making the decision and making the agreement to recommend the pay award to voluntary sector managers, to executive officers, to GP members, and to lay members and the secondary care doctor. The committee agreed the recommendations to make the award, as say, to the exec members, exec directors, GP members, and lay members and secondary care, and that's what we are recommending to governing body. Happy to take any questions.
Okay. Obviously, there is a conflict of interest for all of us on this, but it is recognised that this is the process to do it. Are there any questions before we go on to agree this? Okay, is the board happy to agree this or ratify? Ruth, what's the terminology? We need to ratify this.
No, you're making the agreement.
We're making the agreement.
You're
Okay.
making the agreement that is recommended to you by the Remuneration Committee.
Okay. I see virtual hands up from everybody. Simon's got a new button that actually says yes. Okay, so the board has agreed this. So thank you. Okay. We've got the engagement and comms update from January. Debbie's already talked about.
Yeah, I think it's self-explanatory, Chair, isn't it, really? No other questions. I'll take.
Any questions, comments? No. And then there's just integrated care system, Chris.
So just take any questions, Chair, if anyone's got anything to raise.
Okay. No, members, Jeff?
Yeah, thanks. From 25th of November, I just reading the COVID update. I think anything over 2 weeks old is ancient history in COVID at the moment, isn't it?
Yeah.
But yeah, just feedback. There was the discussion at the end, sort of about sort of chairing the meeting, which I think sort of comes on to sort of partly Chris's sort of early comments about future commissioning and ICS, which still needs sort of looking at in terms of that transition period. But yeah, if anyone's got any questions.
Okay, any questions? Okay, if there aren't any questions. All right, okay. Anyone to raise any future agenda items? We have the glossary. There's no other urgent business has been notified to me. I don't think there's anything we need to escalate. The finances probably the risk need to be de-escalated, doesn't it, Wendy, with the surplus we now have? We haven't raised any additional risks. So we now need to call into the public meeting and consider the following resolution: the representatives of the press and other members of the public be excluded from the remainder of this meeting due to the confidential nature of the business to be transacted, publicity on which should be prejudicial to the public interest. So we consider that and agree that, and we will reconvene for the confidential meeting at 2 o'clock. Thank you anybody for watching. Questions are always welcome. I will just